what I want to do is I want to talk about esophageal varices briefly before we get into kind of the rest of it. I think it's going to help you understand a little bit about this case and how it was handled and how badly it was handled. Not so much, you know, once the ER kind of took over, basically the second, set of ER physicians took over. It was really how this patient presented during the night shift, the previous shift, everything that happened. That's really where the issue was. Everything that the staff does later, I agreed with. Parts of it could have been done a little bit different in terms of getting GI on board. But I want to talk about esophageal varices really before this happens, and then overall you're going to realize how horrible this case was handled. So in an article published by the American College of Emergency Physicians, so this is published on ACEP now, it states acute variceal hemorrhage is a serious cause of mortality in the emergency department and can be difficult to treat. In general, upper gastrointestinal hemorrhage accounts for 102 hospitalizations per 100,000 people every single year. The esophageal varices represent approximately 14% of these cases. So again, not a lot, but we see it every now and then. Furthermore, esophageal varices are the most common cause of persistent and severe, that's the key thing there, most common cause of persistent and severe upper GI bleeding, accounting for approximately 33% of these events. Among patients with cirrhosis, 70% of upper GI bleeding episodes are caused by esophageal varices. Gastroesophageal varices exist in nearly 50% of patients with cirrhosis at the initial time of the diagnosis. Now, the article goes on to state for initial bleeding episodes from esophageal varices, 6-week mortality stands at 15%. This is down from, the article mentions a 40%. There's a few studies out there, but overall it was a relatively high percent down to 15%, but still 15% mortality is still pretty significant. And this was down from 40% 25 years ago. This high mortality rate distinguishes variceal hemorrhage from other causes of upper GI bleeding, which often resolve spontaneously and have mortality rates below 3%. This could be, ulcers and gastritis and things like that. Obviously, there's a multitude of others. But given the lethality of this disease, it is more vital than ever for emergency physicians to understand the current therapy for gastroesophageal varices and deliver that life-saving treatment. And so we're going to be talking about it throughout this episode, is how to treat this appropriately, what to do in these situations. Patients can come in feeling, relatively okay after after vomiting up blood. They feel relatively okay. Vitals are relatively fine. And then the ruptured esophageal varices happen. And without intervention, it's nearly a death sentence. So that's how, important this is. It's important for the provider to recognize the potential. A lot of times in the ER, you have patients that seem fine, and the next minute, they're not. So it's almost like you have to plan, you have to prepare yourself for the potential. You have someone that comes in, let's say there's a 16, 17-year-old that took 100 tablets of Norvasc, and they present to you, let's give it 90 minutes afterwards. There's going to be some vital sign changes. There's going to be some issues going on. But what's going to happen as that progresses over the next 10, 15, 30 minutes, an hour, 2 hours is going to be the most critical time. Sometimes you see patients that literally they ingest a bunch of stuff and you see them at 30 minutes after. You see someone that just vomited blood, right? They just vomited blood and they present to you. So you almost have to keep in the back of your mind, you may be stable now, but you most likely won't be. And if you can kind of keep that in your mind, that's how you really can adequately treat these patients. You can get aggressive with the treatment. You know who to call, what to do, meds to start. You do all these things ahead of time. That's how important this is. Now, in terms of the pathophysiology itself, I want to keep this just bare basic. This all results from portal hypertension caused most often by cirrhosis. Now, there are a multitude of causes of cirrhosis. Alcohol is one, NASH is another, so non-alcoholic steatohepatitis, but there are a multitude of causes. I literally just listed just 2. So what you have is increased portal pressure and large blood vessels at several anatomic locations, including the distal esophagus and proximal stomach. As that pressure builds up, vessels can bleed. That can lead to those ruptured esophageal varices, gastric varices, and the list goes on.
ICU boarder, 48-year-old cirrhotic, here for hematemesis.
Intubated overnight, and after 1 unit, PRBCs and FFP was supposedly stable.
Not anymore, weak carotid.
All right, so this is that point when we start to take kind of a deep dive into some of the backstory behind this. I'm going to explain this in detail because, again, I want you to realize how bad this case was handled from the beginning. So we hear ICU boarder. For those that aren't medical and like, I don't know what an ICU boarder is, I am going to explain that. Well, we're 11 hours into this shift. What this means is that this 48-year-old checked into the ER via either EMS or they came in through the front door just vomiting blood and they got brought back. All right, literally vomiting blood. So he would have been seen by either the ER attending physician or the ER resident on the night shift. Now, in episode 1, Dr. Robbie gets sign out from the night shift doc. Not to say there wasn't a resident on during the night shift. There typically is, especially at a teaching hospital like this. But let's say the volume wasn't as, it wasn't as bad, maybe it slowed down for a little bit. The ER attending sent the resident home. I don't know. We didn't see a resident. We don't know what happened there. Realistically, there would still be a resident on. We're not going to let him leave, early in a busy ER like this, right? He came into a busy ER to begin with. So he would have been seen by an ER doc, just like everybody else. Labs would have been done, depending on the story, maybe imaging. We really don't know anything but, cirrhosis and vomiting blood. So however long that took to get the patient admitted, all right. Now, there are no ICU beds available. That patient was admitted to ICU. We're going to talk about that later. But the patient was admitted to ICU. There's no beds available, so that patient basically becomes a hold in the ER. Well, basically, we babysit them until a bed becomes available, and that patient then goes to the ICU. This can happen with a medical patient, progressive unit, ICU, it doesn't matter. There's no bed available. They're in the ER until one becomes available. You are admitted to the ICU attending physician in this case. All right, you were underneath the ER attending physician. You place a bed request and an admit order. The ICU attending physician takes over that case. I assume he's got residents, it's a teaching hospital, so you're going to have residents on this case. They're going to start putting orders in. They're going to see the patient. They're going to start, doing all these things. They're going to come down and see that patient. Now, since they're an ICU hold, the ICU team is going to manage this patient. The ER provider does not continue putting meds and labs in. We're done. It is no longer their patient. Now, in terms of the nursing situation in cases like this, I'm not going to talk about that because a lot of the times it's the ER nurse managing this patient. They're already, backed up, understaffed. Nurses are managing their own patients, and then all of a sudden they have an ICU hold. Sometimes you get lucky and you have one of the ICU nurses come down. A lot of times, believe it or not, it's the ER nurses that are managing that patient in the ER, which I do not agree with. I think once it's an ICU patient, it should be the ICU team entirely managing that patient. But that's my input with that. I'm not going to talk about that in this lecture, but it's an ICU hold. It should be the ICU team managing that patient entirely. So let's say the patient goes into arrest. You lose a pulse. The patient's ICU hold, admitted to ICU attending. They go into arrest. The ER team is going to respond immediately, right? We're going to hear the little, sometimes they hit the code blue button or depend on the situation, but we're going to respond with immediate, literally immediate intervention, start doing CPR, meds, all that kind of stuff. The ICU attending or the ICU team is notified and they come down. A lot of times what happens is they resume care of that patient because it's their patient. A lot of times realize you have a patient that codes. One, it's bad. You get a hold patient that codes. It looks horrible. But you have a patient that's coding, you're doing CPR, and they were a hold, and you get a situation like that. That attending doc that's down in the ER may not even know that patient any of the history because they're a hold. It's not typically a sign-out case. Now, in the patient in this TV series, we don't get much on the history other than the patient likely came in during the night shift, they were admitted, they were in the ER for a number of hours, and they were intubated. All right, so for starters, does the ER attending or ICU manage that patient in the ER? The ICU team does, just like what we just mentioned. The ER team no longer manages that patient. If this patient was bleeding in the night, requiring blood, it would be the ICU team that would get notified and paged. All right, it would be the ICU team that intubated this patient, not the ER attending. The next part of this, if you are intubating a GI bleed, all right, that means it's because you're trying to protect the airway. They have so much blood. The reason you're intubating is to protect the airway, all right? That means they had a lot of blood there. They were bleeding so much, potentially elevated INR. In this case, here they get blood, so they would have got packed RBCs, they would have got FFP, so fresh frozen plasma, and then the patient was reportedly stable. So up to this point, they would have had vomiting blood, stopped, they were ultimately admitted to the ICU hold, they must have started bleeding again, right? They get packed RBCs, FFP, they got all this blood product and they were intubated and then stable again. So already now we have the second red flag that's just, firing off. And so this patient started bleeding again. and they're moved into the higher acuity room. So vomiting blood in a cirrhotic patient is esophageal varices until proven otherwise. You got to hear that mortality rate earlier. This is a serious potential GI bleed and near-death sentence once the varices have ruptured. Up to this point, we hear no mention that GI was ever consulted by the ER, that GI even saw this patient, and it appears the ICU team was actually never made aware of this decompensation. Otherwise, we would see the ICU team in the ER. Oh, I know why. They're too busy, just like the rest of the consults that we always hear, throughout the Pitt. The consult was busy. No, he's in the ER. Oh, he's busy. That's why we don't see the ICU team, guaranteed. So in this case, did the ER doc last shift, so the doc that was on before Dr. Robbie, did he even call GI? This is a patient that when you call GI about vomiting blood in a cirrhotic patient, they're going to get boarded for an EGD. They're going to go in and do an upper scope. Now, is that going to be done now? Is that going to be done next day? Obviously, it depends on the situation and what's going on. Is the patient stable, not stable, bleeding stop, that kind of thing. But they're going to be seen by GI. They're going to get boarded for an EGD. So let's say in this case that GI saw the patient when the patient was seen initially by the first ER attending. The patient would have been boarded for an EGD later that day, likely because they were stable. That's totally fine. Or, depending if it was in the evening, make them NPO midnight. We're going to do an EGD first thing in the morning. Let's go ahead and start all these drips that we're going to talk about that weren't started in this case. But I'm going to go ahead and scope them in the morning. And if he bleeds at all during the night, give me a call. We're going to scope him emergently. All right, that's a typical situation. Other times, you get a GI doc that's on, they'll be like, oh, I'll scope him right now. All right, I've had both of these situations. So it really depends on the GI doc. It really depends on the situation of the patient. All right, so if they got intubated in the night, that is because they started bleeding a second time. We hear they got blood. Red flags. Come on, guys. That patient needed an EGD right now, emergently. We're not waiting till the morning at that point. If GI chose not to scope that patient on, when he came in vomiting blood because he was stable, that's fine. You started bleeding during the night shift. The second time to potentially intervene on this patient was ignored. Any GI physician that is consulted on a patient with cirrhosis coming in vomiting blood is going to see this patient. Any GI physician that did not get called originally, all right, they're going to get called now on that patient because they're intubated and they're getting blood. They're going to go see that patient. I think now you can start seeing the issue with this case. Now with this current TV case, this is the third time the patient is bleeding, all right? This is not the first, this is not the second. They had the initial vomiting blood on arrival to the ER, it stopped. They were vomiting blood during the night shift, they were intubated, blood product, and then it stopped, and then they're still in ICU hold. This is bleeding the third time. So up to this point, we don't know, besides blood product, what meds the patient was on or is on currently. With the mortality rate and how dangerous this bleed is, it's pretty standard to be on octreotide, protonics, and empiric antibiotics. Otherwise, this is truly a delay in care and a delay in the proper management of this patient. Now that we've explained the diagnosis and how serious this is and the dynamics of this case, I want you to watch this play out, and I hope you kind of have a little bit more of an understanding of what's going on.
Shivati, I need you on section.
Why is she bleeding all of a sudden?
Most likely bleeding is from the esophageal varices. With cirrhosis, you get enlarged veins under pressure at the entry of the stomach, varicose veins, and they can burst.
What does that mean?
The cirrhosis from the hepatitis B caused a vein to burst where the esophagus meets the stomach, and that's where the blood is coming from.
So unless this family member was not present earlier, or the patient had no family, the family member would already know this, and the ER doctor would have explained this to them last night, unless the suspected diagnosis of esophageal varices was never discussed because the ER doc missed it, missed the diagnosis, never consulted GI at all. That's why GI didn't come down. They were never consulted. They had no clue about this case at all because they were never consulted. I have so many questions here on this poor and mismanaged case. This is disappointing.
Mel, I'll have you help with the McRoberts maneuver.
Of course.
Hey, Natalie.
Mick Roberts maneuver is perfect. It can help in the case of shoulder dystocia, but it is being done way later here than what it should have been done. 2 minutes since head delivery, and they are just now doing the maneuver? Are you kidding me? Why in the did you wait 2 minutes after the head delivery to start doing this maneuver? Makes no sense. Clearly the individual behind this case was not an OB, and clearly the ER doc they consulted on this case was horrible. Talking about this case specifically, yes, I'm calling you out on this case specifically. Overall, how this OB case was handled was horrible. This episode overall is just, it's just disappointing.
We're gonna lift your knees up to your chest now.
Great.
Justin, is this the worst you've ever seen me?
This is the most I've ever seen of you. You're beautiful. A little suprapubic pressure here. We got you. You're gonna feel me pressing on your bladder.
2 minutes since head delivery.
Fetal heart rate looks good. Normal variability.
You're doing great, Nat.
We hear fetal heart rate good. That does not matter here. The head is out. Distress or not, this delivery is happening. In real life, a monitor is not going to change this case. I talked about that, in part 1. But do you know what will actually change this case? An OB, an actual OB, a real OB, a good OB. Seriously, who wrote this script? I mentioned this in part 1. A fetal monitor is not going to help in this situation. That baby is being delivered. Stop wasting so much time.
Feel free to step in and take over. Another one's coming.
Give me a big push.
Okay, Natalie, here we go. You got this. We're almost there. Keep going. We love you.
Go Team Natalie.
Late decel.
Okay, can you call Dr. Ingram and tell him to come down here, please, from the queue?
What's happening?
The baby's heart rate has slowed, which could be a sign of distress.
Of course the baby is in distress. You didn't need to waste time with a monitor to tell you that. I can tell you that baby is in distress from my office, let alone not even in front of that patient.
So what do?
We deliver this baby.
We got this. We got this.
Do you though? Do you got this? I have my doubts for this entire case. It was mismanaged from the beginning, coming into the ER. They had so many chances to get this patient to labor and delivery, and they failed. Only because of how mismanaged the GI case is, and then this one, my guess again, is the same consulting physician for both, which is sad. Come on, Pitt. I brag you up every single episode, and episode 11 was the worst episode so far anyway. Again, I have not done 12 through the rest of the season yet, but it was the worst episode in terms of being both accurate and realistic in all of the episodes I've done. So far, disappointing.
Eusebio, can you page the OR and tell him to prep for a possible crash C-section?
Dr. Robbie asks who appears to be the nurse, telling him to call the OR to prep for a possible crash C-section. Oh, I've said this numerous times. I said this in part 1. I've said this throughout the TV series. As soon as they said that on screen, anybody that's been following my critiques probably already knew. They were probably like, Dr. Taylor is going to comment on this because this is just not done. No, where is OB? I literally just critiqued this same thing. ER docs don't just call the OR telling them to prep. That is not your job. Where is OB? She would be written up so fast. And if he or she did this before, there's a good chance some firing is going to be happening soon. I do not want to have to mention how many times in the pit we have heard someone say to prep the OR, call the OR. You don't do that.
BP's only 82/46.
Hey, Mom, you're gonna be okay. Rapid infuser, massive transfusion protocol, Pietride bolus and drip, AD pantoprazole and ceftriaxone. Perla, get Robbie in here.
So we hear blood pressure is 82/46. So the patient is in hemorrhagic shock, and this is likely secondary to the ruptured esophageal varices. The resident states to activate the massive transfusion protocol, which basically means the patient is going to get a lot of blood product, which is what the patient needs, besides all the stuff they needed earlier already. They have been transfused in the night. They got blood product, and they reportedly stabilized after blood product intubated, stabilized, etc. Now they're bleeding again. Massive transfusion protocol is being done now, so now they're getting even more blood product. All red flags are still going off. I really hope you're starting to see the issues with this case. Now she states octreotide bolus and drip, pantoprazole or Protonix, and Rocephin or ceftriaxone. Now, if she stated this now, it means the patient never got those medications to start with, and this is bad. Those drips would have already been running normally. The patient would have already received the octreotide bolus, would be on the drip, would have received the first dose of antibiotics already. And in terms of the Protonix itself, either on the drip or more commonly, evidence-based medicine suggests 40 milligrams Protonix BID over the drip itself. Different thing. I'm not going to talk about that. The point is here, they had the meds right, so I really want to focus on the meds right. It's just at the wrong time. All right, this is comparable to like a septic patient. You are septic, you are sick, and there's a numerous hour delay in antibiotics, and they die. All right, there is that delay in care. There's a STEMI, so a heart attack, cath lab patient, where the EKG was not recognized on arrival as a heart attack until it's too late and the patient had a cardiac arrest. And then you look at the EKG and you're like, that was a heart attack. A pulmonary embolism, for example, is diagnosed and the provider forgets to start heparin. You see where I'm going with this. They had the meds right. They were just given at the wrong time. So again, it's not on the current ER team because they recognized what was going on. It would have been on the previous ER team that failed to recognize all of this. These meds should already be started. This is just horrible. So to recap, this can all mean a few things. The night shift ER doc that saw this patient originally diagnosed the patient and admitted the patient, but did not manage this patient properly, did not start the correct medications, actually didn't start anything. But it also means that since this was an ICU hold, the ICU team would have seen this patient. They also missed the diagnosis because they saw the patient. Why didn't they add those medications, right? Sometimes if the ER, starts certain things, they're admitted to ICU, ICU changes certain things or adds other things. So why didn't ICU add those medications? They didn't either. This was another missed attempt, not just the ER, but also the ICU. It also means that GI was likely never consulted either. I can promise you this. If you call any GI physician in the country about vomiting blood in a cirrhotic patient, they're getting blood product, right? They're currently being transfused and you call GI and say, hey, I have this patient, they're actively getting blood product and has history of cirrhosis and they're currently vomiting blood, intubated overnight. They're gonna say, I need you to start this and this and this and this. That's what's going to be done. If you call GI in this case, they're going to have you start those medications. The entire hospital is risking a lawsuit in this case. Horribly mismanaged patient. So you may be saying, Dr. Taylor, what needed done in this situation? Patient comes in, even if stable, history of cirrhosis, vomiting blood, even if only one episode prior to coming in. This can be what's called a sentinel bleed. This is the small bleed that happens, sometimes a little bit bigger, but this is the bleed that happens before the massive bleed, all right? This is your time to catch it. This is your time to really evaluate what's going on. Be like, dude, I need to get intervention. I need to intervene at this time. I need to get GI on board. We're gonna be doing a lot of things, right? The sentinel bleed is basically your chance to intervene here before that potential death sentence of the massive GI bleed. So let's say you have this patient, vitals are stable, hemoglobin stable, you give a call to GI, you explain the case, what's going on, episode of bleeding prior to arrival, currently stopped, patient stable, all right? You call GI with that. They're gonna tell you, go ahead and start Protonix, Rocephin, and octreotide, all right? You start then all those medications. A lot of times you can start those before calling GI, and I routinely will do that. It's kind of two birds with one stone. I'm gonna order these medications, and then at the same time, I'm calling GI. So it's not uncommon. The point is that's what's gonna happen, all right? Some docs would do an EGD at that time, like, yeah, I'll scope them right now. Or, if it's later in the day, the patient's stable. Again, what we talked about earlier, they're gonna, go ahead and scope them in the morning, all right? But what's gonna happen is that, let's say that patient stays, stable, they're on Protonix, they're on Rocephin, they're on octreotide, they're seen by GI, they're gonna be boarded for a scope first thing in the morning. We're typically going to put them in the progressive care unit or in the ICU because they have a high risk of decompensation. All right, this would have been the perfect scenario. All right, but this would be too easy. This is a dramatic television show, right? This is medically dramatic. We want to dramatize everything, so we're just going to mismanage this case, and we're going to watch all this stuff play out. Let's just mismanage everything and make it really unrealistic for TV to the point that it's exciting and it's dramatic, and let's advertise it as realistic. Makes no sense. Come on, guys. Now, on that same patient we just mentioned, all right, let's say in this situation, stable. They're now a hold, all right? So this is a normal situation playing out. You've already spoke with GI, they're on the meds, they're boarded for a scope in the morning, all right? They've already been seen by GI. And they start bleeding again during the night shift, all right? They had to receive blood product. Again, ICU is being notified, GI is being notified, the patient's being intubated. ICU would have actually called GI and they would have been scoped emergently right there, all right? They would have went to endoscopy, or potentially bedside, depends on the ER and your abilities. Wouldn't have been done obviously in the hallway. So again, I'm not going to critique all that. That's a different situation. The point is they wouldn't have been scoped in the morning. That's kind of the caveat with this. It depends. Patient stable, not stable. A lot of times when you admit these patients, if the scope isn't until morning, the GI doc's going to be like, well, give me a call if anything changes. Hemoglobin starts to drop, patient symptoms change, and that's an emergent EGD. So in the TB case, because none of this happened, we now have a patient 11 plus hours with a delay of care, potential delay for diagnosis, but a delay in care with a mortality rate rising by the minute without the proper medications. Wow, is this a poorly mismanaged and handled case.
Hey, Peggy, where's Robbie? Thank you. Robbie, MTP from bleeding varices and trauma 1.
A little burning from the local.
Oh, fuck, that hurts.
If I could get my hand inside under the baby's head, I'd release that lower arm.
All right, so Dr. Robbie's putting his hand in. I'm trying to understand what he's doing, as it does not quite make sense. I think what he's trying to do is deliver that posterior arm, which in the setting of shoulder dystocia would help with the delivery. But I would argue this is an OB maneuver. This is not an ER doctor maneuver. I don't know one ER doctor that would have done all these things in this case, including waiting 2 minutes for a McRoberts maneuver and then trying to deliver the posterior arm. Now, I'm sure someone, potentially could comment, but Dr. Taylor, what happens if you're at an ER in the middle of nowhere by yourself? You don't have OB, hours from anybody. That's not the point of this critique, because we're critiquing the hospital for the resources and staff that it has. This is not being critiqued from the standpoint of a rural ER with nothing. That's a whole different scenario. That's a whole different critique. We're reviewing this for the resources that this hospital has.
3 minutes since that delivery.
Dr. Robbie.
Yeah, my hands are a little tied up at the moment. I'll need the Minnesota box. Who's in there?
Dr. McKay.
Tell her to go ahead and get set up. She knows what to do. I'll be there as soon as I can.
Yeah.
I'm Dr. Myers with obstetrics.
Nice to meet you.
And who's the father?
We are.
Oh, and who's the mother?
We are.
Roger that. OR is prepped and ready. Do we need to go up?
Not if I can rotate this posterior shoulder.
What the f***? It does not matter at this point. Who is the mother? Who's the father? We are in an emergent situation. This is horrible. It would be like a patient potentially minutes from death, and the doctor that can save your life walks in, all lackadaisical, into the room, introduces themselves, talks a little bit. No, that's not the time for that. This is the time to save a life and talk later. Certain situations in emergency medicine allow for that. This is one of those. Sure, come in briefly, introduce yourself. Hey, I'm Dr. So-and-so, I'm the OB. Get right in there, do your job, do what you need to do, take over that case. I have to say, this is the worst portrayal of an OB on television. It may be in the history of television. No, I can't quite say that, because there's probably other TV shows and movies that portray an OB. But what I would have to say to that is this is probably the worst portrayal of an OB by a TV medical drama that advertises itself as realistic. That's probably the best thing to say there, because obviously there's a lot of other TV shows that advertise an OB, and you're looking at it, you're like, no, an OB wouldn't do that. So that would be the scenario. Just horrible portrayal. For any OB watching right now, this critique, again, well, thank you for that, but again, I apologize on behalf of the Pitt for how they portrayed you. A real OB in this case walks in, may even briskly jog in. I've seen OBs jog, I've seen OBs run. In this case, that's what's gonna happen. They're gonna go into the room, briefly say, I'm so-and-so, they're gonna put gloves on immediately, or they actually already have gloves on, depends on the situation. They're gonna take over that case. Any OB knows what needs done and does it. If people are in the way, oh, they'll move. Overall, if an OB came down like this late in the game, lackadaisical, responded like she did here, it means there's probably other times that she's done this. There's probably incident reports already on this provider. There's probably patient complaints on this provider, probably numerous write-ups, and there's a good chance she's already on the chopping block. This is 100% not acceptable. Now, before I said no OB was consulted on this show, I can assure you, after seeing this, there was no OB consulted on this show, because no OB would portray themselves like this. This is crazy. No OB would do this. Horribly handled case, and it's a shame on the Pitt for allowing this to happen. You needed not just a better consulting physician for this case, you needed an actual OB doc.
All right, there's the elbow.
Make sure it's flexed.
It's flexed. Good call.
We're getting closer. Just stay with me, okay?
I'm trying.
Okay, I've got control of the head.
Oh, that
Arm.
hurts.
Rotating the posterior shoulder. Up and out.
Fuck.
Perfect.
You're right there. Give me one good push.
Yeah. Good. Hey, we got a baby boy.
I've got a stubborn set of twins upstairs, admitted to postpartum. Congratulations, everyone.
What the hell? OB is just leaving? Ma'am, this is your patient. I can tell you this, no OB in the planet would act like she did here after what, a 3 to 4 minute shoulder dystocia case, and they're just gonna walk out? Are you kidding me? Come on, Pitt. Up until episode 11, I've said this before, that this is the most realistic and accurate medical drama. While not 100% accurate and realistic, it is the most realistic and accurate medical drama. This entire case was the furthest possible away from that statement.
Good job.
He's pretty quiet.
Sometimes it takes him a minute. Put the baby on a pulse ox and a heart monitor. Hey, Amy, swap out with me.
No, dry and stimulate.
Vigorously. Very vigorously.
Shouldn't he be crying by now? Heart rate is 95.
Too slow.
Such Collins PBM.
Tiny volumes, once per second. This kid needs oxygen. Come on, baby. Let's breathe.
Section ready?
Ready.
Dr. Ingram?
I'm opening the intubation tray. Yep. 1 minute APGAR is 3.
Isn't that graph supposed to be 9 or 10?
What does that
Come on,
mean?
baby. Breathe, baby, breathe.
So obviously this is a doll, so I cannot critique too much on this. Not all babies will cry immediately, especially in a case like this that was a complicated delivery. The baby obviously needs oxygen, but if they didn't screw up all the stuff I mentioned earlier and the delay of everything, of how long it took for the McRobert, all these things, or just the fact that they were in the ER and not in labor and delivery, I would argue that they wouldn't be in this situation to begin with.
There we go.
That's good, right?
That is very good, very good. Okay, you got this?
Yeah, go.
Looking much better.
Hemorrhagic shock from varices, failed medical therapy.
She states hemorrhagic shock from varices after failed medical therapy. No, to fail medical therapy means that you were given actual medications and then failed. Like if you have an infection, you're on antibiotics, you're on your antibiotics, you get worse, you go to the ER, they admit you on IV antibiotics, you failed outpatient management. Like you failed medical therapy. She didn't fail anything here because she didn't actually get the medications. She didn't get any medications up to this point, including the meds that are standard of care in a variceal hemorrhage. Anyway, these next few references come from the Division of Gastroenterology and Hepatology and the Department of Medicine at Lankenau Medical Center in Wynwood, Pennsylvania, and of course the Division of Gastroenterology and Hepatology at Thomas Jefferson University in Philadelphia. So they cite an article published in the Clinical Liver Disease Journal, in quotes, they stated variceal bleeding is a devastating complication of portal hypertension. EGD is widely accepted as the gold standard method to detect esophageal varices. In another article, according to the Mayo Clinic, the article states, bleeding esophageal varices are life-threatening and immediate treatment is essential. Treatments used to stop bleeding and reverse the effects of blood loss include using elastic bands to tie off the bleeding veins, medicine to slow the blood flow into the portal vein, that was the medication that we already talked about, and diverting blood away from the portal vein. So they kind of summarize some of the treatment for that. So again, in this case, the patient didn't fail medical therapy. It's 11 plus hours way too late. The patient never failed medical therapy. The physicians failed her. Every physician that saw this patient failed this patient. She went that length of time without proper treatment. Standard of care was not met in this patient, and this was a potential lawsuit. Again, both these cases were horribly handled up to this point. I don't even know how many times I've said the word horrible. It's bad. Like, it's bad. It's to the point I just didn't want to finish this. Now, with the procedure that follows, though, this was great. It kind of sort of made up for it because I get to talk about that procedure and super excited about it because I'm going to, kind of put an example on the screen for you. And so we're going to go through that together. So with the procedure that follows, that was awesome, but I think that's why this TV medical drama did everything with this case. so that we can see the procedure that follows. But I would argue we wouldn't be at this point if this case would have been handled appropriately and to the standard of care.
Suction stopped working.
Because your canister is full.
I'm on it.
Oh my God.
Someone please take her out.
Mom.
Thank you very much. By the way, that is not how you raise patient satisfaction scores. Okay, Dr. McKay, do you want to explain to Giovanni here all about the Minnesota?
Ah, yes, the Minnesota box. As with a lot of procedures on the Pitt, I'm going to place a video on the screen. We're going to talk about it. This is courtesy of MRAP, discussing placement of a Minnesota tube for bleeding varices. Now, since a lot of the procedures, if not all the procedures on the Pitt actually utilize MRAP, why not watch the actual video and let's go through this together before the actual procedure takes place? And I think it's going to kind of help you understand. You're going to be able to see the basically the similarities and be like, dude, this is so accurate. This is so realistic in terms of this procedure itself. Your standard kit will have the tube itself, 2 3-way stopcocks, 4 dual lure lock caps, Christmas tree tubing connector adapter, clamp with tape around the tube so you don't cut your tube, manometer, 50cc syringe, marking pen, lubricating jelly, and a traction device. Curlex is used in the case of this particular video. You're going to need a liter bag of saline as what they use here and a bucket of water. Obviously, a few modifications can be made in terms of the traction device itself, but that's what they're using in this particular video. Now, there are 2 balloons, one for the esophagus and one for the stomach. You also have suction holes for the stomach and suction holes for the esophagus. There are 6 ports total, but we're only going to talk about the useful ones. So let's go through what she's holding here in this particular part of the video. There's one port for suctioning the stomach and another port that looks very similar that is meant for suctioning the esophagus. Not every patient will need both inflated, which is really the point of this suctioning, which is to determine, do we have blood in the esophagus, not the stomach, vice versa, or both. There is a port for inflating the esophageal balloon. One of the ports has a manometry port, and the other is for inflating the stomach balloon. If you remember, we have 2 3-way stopcocks. One of them gets placed into the stomach balloon, and the other into the esophagus balloon. Next, you're going to check the balloons for leaks. She puts them in a bucket of water here and checks for any air leaks via bubbles. Great technique. Realize in an emergent situation like this, you don't have time to do that. Some patients, this bleeding looks like an exorcism. We don't have time to check for leaks. We just do the procedure. This is considered a potentially life-saving procedure. In the case of this video, though, we can take it step by step. Once you've checked for leaks, go ahead and remove that air. Next, you lubricate the tubes and the balloon. This goes in very similar to an OG tube or an oral gastric tube. Remember, the patient is already intubated in this case, so one hole is gone. So all you have is one hole left to get this tube in. Sort of makes it easier. It's still difficult, but it sort of makes it easier. Yes, the blood is all over the place, but at least you get some help here since the patient is already intubated. You want the stomach balloon entirely in the stomach. You inject 50 cc's of air into the stomach balloon and then get an x-ray to confirm if it's below the diaphragm. You can see how this would be an issue in someone that is actively spewing blood, and this is like really, really bad. But you're gonna get an x-ray to confirm it's below the diaphragm and in the stomach. This is why you need to make sure you're down far enough. The key thing here is that you're only injecting 50 cc's. You only need a little, just in case. Remember, this is to confirm. You do not want to be in the wrong spot, fully inflated, then you get the x-ray. That would not be good. Once confirmed, you can fully inflate the balloon. The Minnesota box stomach balloon holds 500 cc's of air. That's a lot. In this video, you can clearly see all of the pushes of air that she is doing here. Remember, we are trying to tamponade the bleeding. We're not doing just some small balloon here. We're trying to compress the varices, to compress the walls. This takes a lot of air. Think of the size of the stomach itself. You have bleeding varices, this inflated balloon pushes against it and the bleeding stops. This is temporary only. This still needs fixed. When done, cap it off and take the syringe off. The important next thing is traction. This is where the Curlex comes into play here. In the video, she makes a knot and hangs it on an IV pole. You don't need a lot of pressure for this. Next, she hooks up suction to the gastric port and suctions out the stomach. Once this is all done, you're going to clamp the port utilizing the Kelly clamp. Remove the suction from the gastric port. Next, find the esophagus port, attach suction here. We're looking for persistent bleeding, and if so, then inflate the esophageal balloon. Some patients may have esophageal varices that are bleeding. Some, they have gastric varices. Some have both. Now, she uses the manometer in this video. I'm not going to explain that for the sake of time. Now that you've seen this procedure, you're going to see a little bit later of just how exactly spot on the Pitt made this.
So, best way to stop the bleeding is direct pressure. First balloon goes in the stomach as an anchor. Second runs the length of the esophagus with direct pressure on the varices.
First, we want to inflate the balloon underwater like a bicycle inner tube to check for any air leaks.
Giovanni, subcock in the porch.
Use a 50 cc syringe.
Suction's good and running.
I got it.
What did you give me? Because I feel worse. I told you that I got better last time with morphine.
I have a morphine-like drug called Bupe. Works the same way and faster. Goes right under your tongue. If this doesn't work, we'll switch to morphine. But let's try this first, okay?
I just want the pain to stop.
Open up. Lift your tongue. Leave it there and let it dissolve. We'll be back in 10 minutes.
Just so I'm clear, our plan is lying to patients.
I didn't lie. Bupe is a morphine-like drug. Binds to the same receptor.
He said he isn't an addict, so why give him an opiate agonist to treat his withdrawal symptoms?
Because I don't believe him, and I know this will work. Then, once he feels better, we can get him to admit to his addiction and treat him long-term.
If you say so.
First, do no harm. Then do what's best for the patient.
So buprenorphine is a partial opiate agonist, meaning it does target opioid receptors in the brain, but to a lesser extent than that full opiate agonist like heroin or oxycodone, things like that. For starters, in this case, residents don't just give these meds, nurses do. So already that's not realistic. I will critique this every time. Residents need to stop giving meds the nurses give. Nurses will have to chart what time it was given. Residents don't just give the meds, then go find the ER nurse and be like, hey, I gave the med at this time. That's not how this works. Like, why are we doing this? Pitt, why are you doing this? Everything needs documented. For another thing, like we talked about earlier, I would question doing all this without any labs, blood work, anything back. I would argue no good ER doctor or ER resident is going to administer this medication themselves without the nurse to a patient before blood work is back in a case like this. The resident hasn't even staffed the case yet with the attending. I said this in part 1, but I'm starting to gauge here that the physician behind this episode was potentially different than the previous episodes. I don't know if that's true, but there are just too many things in this episode that are not realistic, don't make sense, and are just overall, really it's heartbreaking.
Here you go, hon. Langdon called the main line.
You gotta be kidding me.
Princess answered, told me you were busy, just wanted you to know.
Okay, noted. Thank you.
You see anything? I don't have to.
Just have to push the tongue out of the way in order to pass the tube.
Okay, here we go.
Heart rate's 124, BP still only 84/42.
Eating is still brisk.
Get another unit on that infuser, please. How far did you go?
50 centimeters. Dr. Robbie?
Did you say 50 centimeters? Yes, that's plenty. Inflate the gastric balloon. Start with 50, and then we'll check the placement of the stomach with an X-ray.
You can already tell how spot on the procedure is compared to the MRAP video we just watched. My critique is not, again, with the procedure itself. That's spot on, it's very realistic, I love that. My issue with this entire case is the potential malpractice and misdiagnosis involved in this case. That was hard to watch. This case had negligence. It did not meet standard of care. Are the writers trying to portray, this as a potential lawsuit case? Sure. Then I guess you could say this is realistic if that was the intention. But I doubt it. Or do they just drop the ball on how this patient should be managed and, assumed it was correct, which in that case it would be an epic fail and 100% not realistic.
APGAR is now 10.
Go on. Yeah? Yeah. Okay, little one. Okay. All right, support his head right away. All right. There you go. You're a natural.
The only reason I paused here is because out of all of the horrible things that we watched, on this mismanaged OB case, that was a struggle for me to review. This was by far the best scene of this entire episode. This is truly a happy and heartfelt moment. I love this. I would much rather pause here and just stay on this scene. Like, I love this. I love this. It's refreshing. It's terrific. I would just rather just pause here and be done.
Whenever you're ready.
Okay. Already miss your dad.
I'll be up soon.
Okay. Can I put my legs down now?
As soon as your placenta's out.
Oh.
Breathe. Good, good. Here it comes.
Oh, wow.
What?
That's a lot of blood.
Starting a second line, spike a liter of saline.
On it.
What's going on?
This happens sometimes. We have to have the uterus clamp back down.
Okay, so this is a postpartum hemorrhage. If you recall from an earlier critique, I spoke about postpartum complications. I'm not going to recap all of the postpartum emergencies here, but I wanted to focus briefly on postpartum hemorrhage specifically, since this is how the rest of the scene is gonna play out. What's interesting about this scene is that they seem like it was more of an emergency with the postpartum hemorrhage than they did with the shoulder dystocia case, and realistically they both should have been treated as emergencies because they both were emergencies. Both the shoulder dystocia and the postpartum hemorrhage are emergencies, not just this part. So the focus was really off with this. Again, this is such a simple thing. They should have been this urgent or emergent in how they're acting, with the postpartum case that they were with the previous shoulder dystocia case. All right, so the Obstetrics and Gynecology Journal, specifically the Committee on Practice Bulletins Obstetrics, they stated the American College of Obstetricians and Gynecologists redefined postpartum hemorrhage as blood loss greater than 1,000 mils or 1 liter, or signs and symptoms of hypovolemia in the setting of bleeding within the first 24 hours. So that becomes kind of your diagnostic criteria for postpartum hemorrhage. So this next reference is published in the Lancet Global Health, titled Obstetric Hemorrhage Prevention, Recognition, and Treatment. States the majority of postpartum hemorrhage etiologies can be remembered by the 4 T's. So tone, trauma, tissue, and thrombin. Tone of the uterus, or atony, comprises 80% of postpartum hemorrhage. So at the time of delivery, blood flow to the uterus reaches 500 to 900 mils per minute. After delivery, high levels of oxytocin help potentiate uterine contraction and vasoconstriction of uterine arteries in order to minimize blood loss. The pathophysiology of uterine atony is often attributed to risk factors. So the biggest risk factors for that are impaired contractions from local inflammation and acidosis of uterine tissue, so chorioamnionitis, downregulation of oxytocin receptors, so prolonged labor, and diminished actin-myosin interaction from an enlarged uterus, so fetal macrosomia, multiple gestation pregnancies, etc. Now, for the sake of time, I didn't want to talk about the remaining etiologies. I just wanted to focus on, talking about uterine atony, which we mentioned is roughly the cause of 80% of the postpartum hemorrhage cases.
Starting uterine massage, 40 of oxytocin in the back, 800 mics of sublingual misoprostol, and 1,000 of TXA. 2 units from the blood bank, just in case. Call OB and get Robbie.
All right, so she states 40 of oxytocin, 800 mics of sublingual misoprostol, and 1,000 milligrams of TXA, or 1 gram of TXA. For starters, there's actually no evidence for sublingual misoprostol in this setting. No ER doctor is going to give that. Come on, Pitt. You guys know this. Consult better. The oxytocin and TXA, on the other hand, will be your best bet here, and both would be highly recommended in this setting. 2 units from the blood bank, that's perfect. 100% agree with that. Overall, the dynamics of this entire case are just weird. The shoulder dystocia should have felt just, like an emergency in this part as the later scene, but it didn't. A good OB also would not have just left like we just saw here.
Why is Dana still here?
She refuses to leave. That's perfect placement.
Whoop, whoop. The portable X-ray. I mentioned this on previous critiques, mainly at the beginning of needing portable X-rays more often. What you're going to notice here is a beautiful X-ray showing the inflation of that gastric balloon within the stomach. And remember, compare that to the one we just watched in the step-by-step on the model earlier. Love this. Overall, the procedure in general, the procedures in the Pitt are generally spot on. It's really just everything else that ends up being the issue. Sure, there's a few critiques here and there on one of the episodes. I think it was either episode 1 or 2, whatever one had had the pericardiocentesis. I think it was episode 1, where I even questioned the angle that they were putting that needle in. It wasn't on the same angle. It wasn't angled towards that left shoulder. So even the angle was off. But overall, in general, the procedures are pretty spot on. It's just everything else.
She wants to finish her shift.
Of course she does. Never met a charge nurse who wasn't a stubborn bitch. Okay. In an adorable way, of course.
I honestly don't know what we'd do without her.
The mouth's filling up again. It's like a fountain.
Dr. Robbie, we need you in trauma too.
Yeah, okay. I'll be right there. She's still bleeding higher up in the esophagus.
Natalie.
Got this?
We got it.
Take-
Perla? Yeah. She's not bleeding in her stomach. We have to inflate the second balloon up in the esophagus to do the job.
Dr. Robbie,
Yes,
we need
fuck,
you.
I'm coming. Fucking Langdon.
This port is in the esophagus. With a ton of blood. Mystery solved.
So very good here. The patient is still bleeding after tamponade was attempted in the stomach. The gastric balloon is inflated. So in this situation, next up is the esophagus, very similar to the video. What's just messed up overall is like the whole entire time, nobody is called GI. GI is not even aware of this patient. Multiple times that they could have intervened and GI has no idea what's going on. Somebody page GI, please, or have them page, like speak with GI here. Like this is just crazy. This horribly mismanaged case. This is a type of case that's going to be reviewed big time. This would not just be a peer review, so every physician that handled this case is going to get reviewed. In residency, like in a residency program, this is actually what we call an M&M case. This is a morbidity and mortality case. This is discussing that case in particular. If you watched ER, again, I don't remember which season, but there was an episode where one of the docs was discussing a case literally in front of an auditorium of people. That's what an M&M case is like. That's a morbidity and mortality case. Some of those things you're getting drilled. So this is the type of case that would be. On top of that, this is a potential lawsuit case. That's how bad this case was handled. It's horrible, horrible.
Pump up the esophageal balloon to 30 millimeters mercury.
That's an insufflator and a manometer?
Yep, just like a fancy bike pump. We are at 30 and shut the stopcock.
Barely any blood coming from the esophageal port.
The balloon stopped the bleeding. Tomorrow, GI can cauterize the veins.
All right, so we hear her say, tomorrow GI can cauterize the wound. Now, this implies, okay, did she speak with GI? Or is she just assuming GI can cauterize tomorrow? You want to delay this another day. Now, granted, the patient just got tamponade, but you want to delay this any longer. GI at least needs to see that patient now. Don't state, to everybody else, GI can cauterize the wound tomorrow. Let GI make that call. Somebody page them, discuss the case. They're going to come down and see that patient. You want to delay this another day? You're all getting sued. This is ridiculous. After having explained earlier all the issues involved in this case, GI still has not seen this patient. Now what you have is a mismanaged originally, potentially undiagnosed, admitted without drips, no meds, no GI consult, bled overnight, intubated, transfused blood, remained in basically an ICU hold in the ER. ICU never saw that patient, started bleeding again, got a Minnesota tube as the patient was in hemorrhagic shock, got transfused again, and still GI has not seen this patient. Ridiculous.
That was awesome.
I learned from the best.
Is she gonna be okay? We're doing everything that we can.
Massive PPH on MTP and all uterotonics.
Any rupture, any inversion, any retained products.
Checked for all, none present.
This is all my fault.
Second unit's going up.
Still tacky at 130, systolic's only 84.
Let's try carbopros, 0.25 milligrams IM, and get a Bakri balloon from Central.
You can talk to her. Get in there. Tell her some of your favorite memories with her. That'll help.
Oh man, the Bakri balloon. If that wasn't the tipping point in all of this, right? From the beginning, all these different steps, and now we have to, deal with the Bakri balloon. No ER doctor is going to do this. A Bakri balloon is basically tamponade. Think of it very similar to the gastric balloon we talked about with the Minnesota tube. That's why I think the same doc that consulted for this episode probably did it for the whole episode. This wasn't just multiple different doctors here. Everything kind of starts showing that pattern here. It's like a catheter that goes into the uterus. When inflated, it's going to push against it. I can tell you this, no ER doctor is going to do this. This is 100% not realistic. I might as well stop saying this 100% realistic, because this entire case is just horrible. This episode pisses me off from an educational, realistic, and accuracy point of view. However, From an entertainment point of view, this is awesome. From a non-medical standpoint, if you watch this, this is like the best episode. You're like, man, this is so realistic. The birth scene, the emergency, the procedure, this is awesome. From an entertainment point of view, amazing, no critique. However, if we're judging off an educational, realistic, and accurate point of view, horrible.
See, need a fresh saline bag.
On it. 3rd and 4th units are coming up. FFP is also infusing.
Keep going, keep talking to her. More memories, it'll help.
There was the time that we got that glass table off of Craigslist, and we went to go pick it up, and they mugged us, and they stole it back from us.
Estimated blood loss?
About 2 liters, maybe 3.
What she had?
Oxytocin drip, TXA, carbaprost, massive transfusion protocol.
Expect saline?
Balloon is past the cervix. How much should we put in?
Up to 500? If that doesn't work, she'll need a hysterectomy.
Hysterectomy.
This is going to work. Come on, keep talking. More memories. It's good for her. It's good for all of us.
And the time we binged Game of Thrones 2 months before the finale because of FOMO.
Natalie. Hey, Natalie. Natalie, stay with us.
Oh, it just keeps getting worse. OB comes back down. She should not have left. In fact, I'm going to say it again. This patient should never have came to the ER. This OB is just, she's an awful OB. It's hard to, again, talk about this case because it's just so poorly managed. Both these cases are so poorly managed.
Oh, I'm feeling a lot better. The nausea is gone.
What about your stomach aches, muscle cramps?
I mean, I'd say I'm 75% better.
Blood pressure and heart rate are back to normal.
Incredible.
You sound surprised.
Oh, no, I'm just relieved for you. So.
Good news is you can have another dose. That should get you back to 100%. Tongue up.
Drug seeking or not, I think overall how this case was portrayed was not good. And of course, the resident is again administering the medication herself, which would not happen.
I think we did it.
No more blood loss. Thanks for your help.
I'll tell OR to stand down. Nice save, Dr. Rabinovich. Dr. Collins.
Oh geez, so she goes, nice save. In real life, this OB would have been written up and an incident report would have been filed for this case. If she is like this on this case, she's like this on other cases as well. And this OB is probably near the chopping block, would be my guess.
Pulse ox 99, BP 102/68.
She doesn't need the mask.
Thank you for being my best friend in the whole world.
Her family. How long does this thing need to stay in you?
12 to 24 hours. We'll take it out tomorrow.
We're going to admit you to the ICU for overnight monitoring.
Thanks, Dr. Robbie. Thank you, Dr. Collins.
I take it back. The only thing great about this case, besides the dads holding the baby, is the decision to admit the patient to the ICU overnight for monitoring. 100% agree with this. I would do the exact same thing. Overall, I give a lot of credit to the Pitt, but this birthing scene was just horrible and needed better representation. Again, any OB that's watching, that watches, I apologize to you on behalf of how the Pitt portrayed you. It was awful. Any ER that functions like this, any ER residency that functions like this, I would not recommend. Not recommend at all. I wouldn't rank this program. I wouldn't go to this program. Please do better on season 2.
What happens next? Once she's stabilized, the GI specialist can do an endoscopy to try to cauterize the bleeders, or they might put in a shunt to take pressure off the bleeding veins. And she'll go to the top of a transplant list for a new liver.
The top of the list? It's that serious?
It is, yeah. But once she gets her new liver, she should be able to return to normal life.
Okay. I guess I always knew that this day would come, but somewhere in the back of my mind, I hoped that maybe it wouldn't.
It's a lot for someone your age to handle. Is there anybody we can call, or?
Oh, no, it's just us. It's been that way for a long time.
I'm sorry, that's really hard. Yeah, it's good she has you.
Yeah, I'm the same age that she was when she first got Hep B. I know it's hard to believe when you look at her, but she was a wild child and an intravenous drug user. But she got clean the day that she found out she was pregnant with me, and she has been ever since.
She sounds like a good mom.
She's the best. Are you close with your mom?
Sure, yeah. Like proximity-wise? It's just not the first word that comes to mind. It's complicated.
Usually is, right?
Yeah.
I mean, my mom hasn't been perfect. I mean, sometimes I really hated her, but I always loved her. And I knew that she loved me.
Yeah, it's a long road ahead, but it's a marathon, not a sprint. All you can do is take it day by day. We have a great social worker here, Chiara Faro, if you want to talk to her.
Maybe a little bit later. I think I just want to be with my mom right now.
Yeah, of course.
Yep.
If you're a GI physician watching this episode, I'd love for you to comment on this case and how the Pitt managed it. Not consulting GI a day ago, not starting any drips, patient getting intubated, blood products, still no drips, now getting both stomach and esophageal tamponade with still no consult to GI. Any GI doc, it doesn't matter if you're an attending, if you're a GI fellow, please comment on this. I'd love to hear your take on it.
I know. Dude, you gotta stop calling me, okay? Yeah. Okay. I'll tell him. Whenever I see him next. Okay. Guess who that was?
God. No, I told you he never calls.
Well, Langdon's desperate to get a hold of you.
You don't say. God damn it. Hey, Jake. Hey, man, how's it going? Everything okay with the passes and the tickets?
Yeah, it's all good.
Want to say hi?
Hey, Jake, long time no see.
How's the festival?
It's really cool. I mean, there's tons of people and there's a lot of cool stuff going on.
Good. Glad you're having a good time. How's your friend?
Oh, she actually wanted to thank you personally.
Hi, Dr. Rabinovich.
Just Robbie.
Robbie, I'm Leah, Jake's friend.
Girlfriend.
Stop, you said you were going to embarrass me. I know you were supposed to be here with Jake, so thank you so much for letting me use your tickets. We're having a blast.
You're more than welcome.
All right, well, we got to get out of here, but thanks again for the tickets, man.
Thank you. Nice meeting you.
You too.
All right, so we're getting close to the mass casualty in the start of episode 12. For those that have only watched my critique and have not watched the rest of the season, sorry I just gave it away, but we're soon going to be seeing a mass casualty event that's going to test the limits of the staff, the ER, the hospital, that's going to take you out of your comfort zone and into a battle zone.
And he still hasn't admitted any opiate use.
No, but again, he exhibited every symptom and now he's 100% better.
And it feels like it was just a few hours ago. I was asking you, why didn't you consult me first? And specifically telling you never to do that again. But instead, you went behind my back and
I did it again.
You did it again, for fuck's sake. Is anybody honest about anything anymore?
She is just now staffing this case. I will say it's not uncommon for senior residents to not discuss or staff a case till later on, especially the third and fourth year residents that are further along in the training. But it does depend on the case itself as well as the attending, the comfortability level. Plenty of times through training, we had docs, it didn't matter if you were a first year, a second year, a third year, or a fourth year resident, or a chief resident. It didn't matter. They wanted to know about the case immediately. It's just how some attendings are. So there's a lot that goes into that. But I was definitely expecting her to staff this much earlier on than she did, especially with what we've seen, of Dr. Mohan throughout the season, including slamming 3%, which was Santos as well, but Dr. Mohan went along with it as one of the senior residents, and she did it herself. Clearly, this is not the best third-year resident, and I would expect her to staff more cases with the attending earlier on. Now, if we're being honest here, if we're being completely honest, throughout the season, I've discussed the year in residency needs to match the experience level, and I would give her knowledge level to that maybe of a second-year EM resident, not a third-year EM resident. If the Pitt changes around the year of the resident, some of the things become more believable. Other things, not so much. I believe Dr. McKay is a second-year resident, if I recall. So far, she's one of the few, her and Langdon, where the actual year in residency corresponds to that degree of training. If you recall back to the canthotomy scene, and Dr. Robbie had her do the canthotomy, she acted like surprised that he was going to let her do it. I can tell you this, no third year, no fourth year would have even questioned that. They wouldn't be surprised. They would have jumped right in. Heck, even second years may have did that. And here she hesitated, but it was believable that she was a second year, because remember, we're only a few months into second year, so I totally believe that, all right? I told you all watching, I would critique down to the smallest detail of each episode.
That was rhetorical. Why didn't you come and find me?
You were a little busy.
Really? Do better, Dr. Mohan.
Yes, do better. What did your labs show? Did you rule out the emergent cause, or did you just jump to that he was, it was all chronic pain and withdrawal and he was drug seeking? You didn't get your attending because he was busy? That's not your call to make. Find us. Tell us you have a case to staff. Even if I'm in the middle of a resuscitation, resident comes in, it's like my own patient, I'm in the middle of a resuscitation, resident comes in to discuss a case. As long as they don't mention names, room number, etc., leaving the specifics out, they can discuss that case right there. That's pretty common. Let's say I have a COPD patient, COPD exacerbation, they're in hypoxic and hypercapnic respiratory failure. I'm getting ready to intubate them, I'm setting up, I have respiratory present, right? I have everybody present, ready to go. And so a intern or second year resident comes in the room because the patient they just saw, they want to staff with the attending first, maybe it's the first time in the year, whatever it may be. And they need something ordered and done immediately. In this case, it's a vaginal, that's a very specific example because this literally just happened. Vaginal bleeding, right lower quadrant pain, positive urine pregnancy at home. The concern is ectopic pregnancy. That's okay. Let's get the blood work, serum HCG, urine HCG, RH type screen, bedside ultrasound. Go ahead and get the ultrasound bedside. I'm going to be in there right after this. We're going to take a look with the bedside ultrasound, see if we see any free fluid, see if we see anything obvious, at least within that right fallopian tube. That is pretty normal. It's not the resident's call to make, oh, the attending looks busy. I'm going to do, nah, he's still busy. I'm going to do all the blood work myself. I'm not going to staff it to the very end. He just looks busy. That's not your call to make. That's not how that works, and a third year should know this. No third year resident, this gets back to what I just talked about where the degree of training doesn't correlate. No third year would say the attending looked too busy or you were too busy, so I figured they're not going to do that. Any third year in the country knows this, leading to the fact that Pitt may give her an R3 title, but really she is the knowledge level of an R2.
Yes, sir.
Using bupe was unconventional, and while it wasn't dangerous, it could be subject for scrutiny, which I really don't need any more of right now from Gloria. I expect a level of this from medical students. I expect more from an R3.
Exactly, way to tell her, Dr. Robbie. Residents don't just give that themselves to a patient in the ER. Dr. Robbie just tells us, she's a senior resident, she should know better. But then again, she did slam 3% earlier, so clearly the training in this residency program is not up to par, which is not on Dr. Robbie, as these residency programs have tons of faculty members and attending physicians that all teach. These programs have numerous faculty members. It's not just one person teaching, numerous faculty members for teaching. So maybe this is a residency where not all the ER attendings are good teachers and only a few are. Something like that would definitely have an effect on the program for sure.
Just give him to Cindy, have her hold him, and then you don't got to think about it. Because I'm your father, that's why. Listen, the doctors are back. I got to go. I'll talk to you later. Yes, I love you.
How are you feeling, Mr. Puglisi?
Oh, so much better, thank you. You guys think that I could have a little bit more of that medicine just for the few days that I'm out here? Just want to be able to walk my daughter down the aisle without shitting myself.
The medication we gave you wasn't morphine. It was something called buprenorphine, or bupe.
Yeah, no, she said that. I mean, whatever you call it, Doc, it worked great.
It's a medicine specifically targeted to treat opioid withdrawal. That's why it worked.
Well, I don't understand.
All indicators are that you have been using opioids. That would include pain medication like hydrocodone, oxycodone.
I told them I don't do drugs. Wow. Oh, you lied to me.
I didn't lie. I said I was giving you a morphine-like drug that got rid of your cravings.
Wow. You know what? This is bullshit. I mean, I can sue all of you. You hear me? I'm not some junkie on the street. Look. I got a family, I got a job, I make good money, I return my shopping carts, I pay my taxes. That sound like a drug addict to you?
Yes. Because anybody can be an addict. You were proof of that. These pills that you were taking, they're not helping you with your pain. They are keeping you stuck in it. A lot of really good people struggle with addiction. It is a brain disease, but social environment and personal choice are also factors.
I don't have a
problem. The good news is that the brain is highly dynamic, as is the environment, but you need to stop now before the damage is irreparable.
No, screw this hospital, okay? And screw you.
Hey, Dr. Mohan will advise you on our proposed action plan. You can either choose to follow it or not. That is entirely up to you. I wish you luck, Mr. Puglisi.
We're giving you a 7-day supply of a drug called Suboxone. We can set you up with a medication.
Fuck off, I'm not interested.
My father passed away when I was young. I don't know if I'll ever get married, but if I do, it'll be without him walking me down the aisle. I'm glad your daughter has you there on her wedding day. I hope she gets to have you there for all of her other big days to come, too.
So side note here, the reason I paused is because I want to talk about patient satisfaction. We've heard about it briefly throughout the TV series. I haven't really commented on it too much, but we're going to kind of take a deep dive into that. Basically, hospitals have certain targets they want the physicians to hit, a certain percentage of overall patient satisfaction. Now, I want to talk briefly here and explain a few concepts that may be unfamiliar to non-medical individuals. And then if you are medical, we are going to have a moment of just pure truthfulness. And I'm also stating my opinion as well. All right, so patients that present to the ER are either discharged or admitted, or they elope or leave AMA. Basically, discharged or admitted, I'm just going to focus on that. They're going to get a satisfaction survey. Every hospital is going to have it differently. Some will actually call the patient and they'll have a survey that they do over the phone. So the question becomes, how does a typical ER, all right, or a typical hospital divide satisfaction between ER and inpatient? So when a patient's seen in the ER, you're going to have a satisfaction score to the ER doctor, and you're going to have a satisfaction score to the admitting team, all right, to the admitting doctor like the hospitalist, all right. This is where it gets interesting, and this is the part of patient satisfaction that frankly no ER doctor likes, all right. Typically all patients that are discharged from the hospital, that satisfaction score goes to the ER doctor. And the admitted patient, so the patient that you saw and got admitted, that score, that patient satisfaction goes to the admitting doctor. All right. Even if that admitting doctor didn't do much and you did all the resuscitation, you did all that stuff, it doesn't matter. You don't get it. They're admitted. All right. That score goes to them. You may be like, wait, Dr. Taylor, I don't think that's fair to the ER doctor. Aren't patients that get admitted in general sicker? You saved their life. Perhaps it was a cardiac arrest, a gunshot, a stabbing, meningitis, STEMI. Guess what? ER doctors don't get that score. The hospitalist actually gets that score. So let's say your ER has a 30% admit rate. That means 30% of your patients that come to the ER get admitted. All right, 70% go home. The patient that gets admitted, the surveys and satisfaction of those patients go to the hospitalist. What do we get in the ER? We get that 70% that go home. Will all 70% fill that out? No, absolutely not. So why is this an issue? It's cases like this, if patients don't get what they want, like Dilaudid instead of morphine, score of 0. Patients don't get the drug they want, score of 0. Patients with chronic pain for years, seeing multiple specialists, no answer. They come to the ER for their third and fourth opinion, and they leave with no diagnosis. They give us a 0. Patient has a 9-hour wait time and later discharged. They get a 0. Coffee is cold and the patient did not get a blanket fast enough. Score is 0. The family never got the Sprite they wanted. Score is 0. Or that patient that takes the survey so seriously, they come in threatening their survey results at the beginning of their ER stay. This happens. That patient comes in and says, Doc, if you don't give me that Dilaudid, it always works for my chronic pain and I want my work note for 3 days. When they call me for my survey, I'm not giving you a 10. Or in the case the patient states, Doc, I can already tell you, if you don't find what's causing my pain for years, I'm not giving you a 10. I'm giving you a 0. And of course, that patient, you just ruled out every single emergent life-threatening condition. You did multiple labs and image. They came in with whatever it may be going on for years. You do this massive workup, labs and imaging and CAT scans. You do all this stuff. You even went out of your way to call even a few specialists to get them follow up. You even got them a PCP. You literally went above and beyond, but you ruled out every single emergent life-threatening condition. At that point, this is all routine follow-up. Guess what? That patient's probably going to give you a 0. Literally every life-threatening diagnosis you ruled out, they're going to get that phone call. They're going to give you a 0. Why? That doctor couldn't figure out what was going on with me. Well, we did. We figured out that it wasn't an emergency, all right? Do you know what score you get for all of these? Again, you get a 0, maybe a 1, maybe you get lucky, you get a 2. Doubtful you're getting a solid 10. And in some hospitals, they only actually look at certain numbers that benefit. So certain hospitals will take 8s, 9s, and 10s, or they'll take the lower, like you don't get the middle one. And so, they get thrown out. So overall, you start to see this score forming of these discharged patients. That patient that you admitted and saved their life, you don't get that score. That cardiac arrest you had that you got a pulse back, they went to the ICU, you don't get that score. That sweet grandpa with appendicitis that you talked about fishing with, you don't get that score. That 6-year-old you admitted for dehydration and the family raved about you, you don't get that score. That patient that you saw for this chest pain, it radiated to his back, you made the decision on a CT, they found a dissection on the CAT scan, you treated it, he got admitted, he went directly to the OR with cardiothoracic surgery, you saved his life, you don't get that score. The patient in this case is likely going to give you a 0. At the end of the day, did you die? No. The ER is a place for emergencies. The ER is a place that we rule out the emergent life-threatening condition. If you walked out of the ER, that satisfaction should be 10. Sadly, as this TV series has shown, they have shed light on patient satisfaction and the stress it places on ER doctors every single day to try to alter their care to please management and to please patients. I hope you can start to see the issue with patient satisfaction scores. Enough of that soapbox. Let's continue.
Knock, knock.
Huh. To what do I owe this pleasure?
I found these. You must have dropped them. Gotta be more careful. You don't want these ending up in the wrong hands.
You can keep them.
You ever think about quitting?
I'm not a quitter.
Oh, I know. You're a happy drunk today. But one day, when your liver fails, and believe me, it will fail, you won't be so happy. It's not a nice way to go.
I'm digging my own grave. Let me.
I don't have to give you the shovel.
So you can explain to patients all you want, but at the end of the day, it's up to them to want to make that change. That COPD patient that wears 4 liters of oxygen and still smokes a pack a day, sometimes they're smart and they actually take off their oxygen while smoking, sometimes not, and they come in when it blows up in their face and I have to intubate them, put them on a ventilator. The stroke patient that skips her Plavix and she still smokes. That diabetic patient that sneaks candy into the ER and eats it while they're on an insulin drip. That 19-year-old alcoholic drinking a pint a day since the age of 15 on the verge of liver failure. All these patients, you can have that discussion about lifestyle changes, but it's up to them to want to make that change. We have resources in the ER to get the patient help, be it outpatient resources, inpatient resources, depending on the hospital, itself and their options. But patients have to want to help themselves as well. It goes both ways.
Keep your distance. I'm already in a bad mood.
I'm just getting some air.
Yeah, right. You're a terrible liar. Hope you're better at security.
Hey, now you're just being mean.
You realize that this is the second person to accuse you of that today. You starting to see a pattern?
No, but I'm starting to see why Gloria's unhappy with your patient satisfaction scores.
So the part of patient satisfaction that Pitt did not mention is what I already mentioned of what goes into the score itself. Management sees a number, but what they don't see is what the ER sees every single day.
When I was born at this hospital, I even volunteered here in high school. I was punched, kicked, spit at, pissed on, had feces thrown at me.
I talked to Gloria. I told her, listen, we got to do something to beef up security. This can't happen again.
It will. It will. Maybe not to me, but to somebody. The world's changed. People are angry. Our tempers are shorter. And we're still just trying to help.
You do help. You do make a difference. One asshole doesn't get to change that.
I think I'm done.
Yeah.
All right, so we're past the breaking point at this time for both the charge nurse and Dr. Robbie. You can feel the exhaustion and the burnout. It is palpable. You often see these AI memes of people, interviewing nurses about their job, and there's a few that interviewed, a doc about his job. The nurse or the doc, they look like they're 65, 75, and, the individual states that they're only 25. And the ER has just aged them. So while that's extreme, this is so true. I'll often say that working the night shift, for example, will take days and weeks and years off your life, not to mention the bad eating habits, the schedule, and the mental toll operating at that level will do to somebody.
I know that one. And I don't blame you. I don't know. I don't know. Maybe what I want and what the patients need isn't what's best for you anymore.
Yeah.
I just honestly don't know what I'm gonna do without you.
You'll figure it out. You always do. You're a good man, Rabinovich. Don't let this place take that from you. Okay? God. Yeah. Code triage. Multiple GSWs. There's an active shooter at Pitt.
You are exhausted. You are this worn out, this close to the end of your shift, and you get that call, active shooter at a festival. You know that you're going to be getting dozens and dozens and dozens of patients at one time. You take that deep breath. This is what you trained your life for. This is what you do. Will you step up? Will you use that skill set? Will you be the ER nurse and the ER doctor that will not give up, that will continue to fight? Will you be that difference between life and death? This is real ER medicine.
Jake and his girlfriend in there.